All right. Good evening, everyone. Welcome, and we thank you so much for taking your time to be here with us this evening. I'm really excited to have a great panel of my colleagues from the sarcoma department. But before we get to that, just a few housekeeping items. So I'm Dr. John Mullinax. I'm a surgical oncologist in the sarcoma department at Moffitt Cancer Center, and we're going to be joined this evening by Doctors Voss, Metz, and Lazarides, and I'll introduce them separately. So before we begin, the content we're going to discuss tonight is not intended to be medical advice. The viewers should consult their physician should they have any questions. You should not rely on information contained in this presentation or webinar for any immediate or urgent medical needs. If you think you have a medical emergency, please call your physician, go to the nearest emergency department, or call 911. Don't disregard medical advice or delay seeking care because of information contained in this presentation and webinar. So again, very happy to have everyone with us this evening. At the end of the night, we will have a question and answer session. So as the presentations unfold, please enter your questions into the Q&A box, which is located at the bottom of your screen. And then we will go through those at the end of all three presentations. So first this evening, I'm really pleased to introduce my partner, Dr. Alex Lazarides. He's an orthopedic oncologist within our sarcoma department. He treats obviously all patients with sarcoma and focuses on those with bone sarcoma. So he'll talk to us this evening about some of the work being done in the orthopedic group regarding limb salvage surgery. So Dr. Lazarides, take it away.
Thanks, John. And yeah, I'm really excited to be able to kind of pile or highlight our group. Just wanted to introduce ourselves since not everyone might be aware. We have currently five orthopedic oncologists. We just hired Sarah Tepper, who is our current fellow. In addition to that, we have three other actively practicing orthopedic oncologists, and then Doug Letson is kind of in our senior leadership. And in addition to that, we have a huge inpatient and outpatient team, including APPs, clinical and research fellows, and residents. We can go to the next slide, please. And like we alluded to, it's all about, having a big team. We're one of the biggest teams in the state of Florida. We have a clinical fellowship and are proud that we've had 14 years of trainees and have filled that every single year. We have also recently launched our orthopedic oncology research fellowship. But in addition to that, we educate many people. So we educate resident trainees from the University of South Florida, as well as residents from Larkin Community Hospital. And it's really a very busy practice. If you look at the state of Florida in terms of full-time orthopedic oncologists at academic centers, there's only about 20 of them, and we have five of them here at Moffitt. So really one of the highest sarcoma volume practices in the US. Next slide, please. So I want to just start by highlighting some of the things that we do that are unique. There's a few different categories, but we really are some of the pioneers in custom implant procedures. These are implants that are designed, 3D printed with engineers, and then implanted to fit defects and help reconstruct limbs that otherwise would be unreconstructable. I specifically specialize in the upper extremity space, and so we've really tried to pioneer reverse shoulder technology, which has been dramatic for improving function in our patients. David Joyce is one of our pelvis experts, and he's really pioneered using computer navigated surgery to help perform our resections and our reconstructions. As a group, we really are experts in mega prosthetic reconstruction. So you've heard about your neighbors who've had a total knee or a total hip. Well, the defects that we deal with are orders of magnitude larger than that and require specialized instrumentation and implants to build that back in. And then beyond just the implants that we're doing, we're also really trying to pioneer functional muscle and nerve reconstruction in conjunction with our plastic surgery colleagues. And I'd be remiss if I didn't mention my partner, Dr. Benitier, who's really one of the state experts in pediatric orthopedic oncology, and he's really one of the national experts in pediatric expandable technology or implants that grow with the patient. Next slide, please. So this is just highlighting some of what that looks like. So you can see here on the left, this is a reverse shoulder historically. These are patients that really wouldn't have much function from their shoulder because we're removing a large portion of bone, a lot of soft tissue attachments. And now with this technology, we've really been able to revolutionize the way they're able to function after surgery. We do replacements all over the body. You can see the lower leg, distal end of the femur, the upper portion of the tibia, entire femurs. And it's a unique circumstance for every single patient, but we have the skill set to really be able to handle things that really nobody else is willing to try to touch or explore. Next slide, please. And this is just highlighting what our intraoperative navigation looks like. We are actually going to be doing a case like this in just a week's time. And really what this allows us to do is ultra precise resections and determine the bony anatomy in the operating room, but also just as important is ultra precise reconstructions. So the more accurately we can take a tumor out, the more accurately we can reconstruct somebody's defect and allow them to be more functional as a result. So this is really technology that few centers are using, but we really have some of the national experts here pioneering this. Next slide, please. And obviously, this is what we're talking about when we think about custom implant opportunities. And so there are circumstances where patients have defects that simply will not be reconstructed with off-the-shelf options. And so we actually have to work with our industry colleagues and engineers to create implants that are unique to our patients and don't exist anywhere else in the world. And this allows us to reconstruct defects that otherwise would not be able to get reconstructed and fixed. Next slide, please. I also just want to spend a moment highlighting our osseo-integrated technology. There's a lot of verbiage here, but we really are currently one of two centers in the state of Florida and the only cancer center that's offering this technology. And what this allows is an opportunity, actually, just like a dental implant, to anchor an implant directly into the bone through the skin and into the outside space. And this has a dramatic impact, especially on our above knee amputees who really can have a tough time tolerating traditional socket prosthetics. And this is an option for those who have failed those traditional socket prosthetics. So this is a technology that we're offering here at Moffitt now, not just to cancer patients, but also to the community at large. We're really excited about launching this. Next slide. Mhm. We can go to the next slide. I think we talked about this already. All right. So when we think about reconstruction, why Moffitt? Well, we're a high volume sarcoma and orthopedic oncology practice, but really, while we have the unique experience to manage these complex limb reconstruction needs, it's all about the team. And Dr. Voss and a lot of the other surgeons here, we work as a team with surgical oncologists and plastic surgeons to be able to do surgeries to treat patients' cancers and get them reconstructed that we otherwise would not be able to do so. Next slide. I just want to shift our focus now because we are very busy clinically, but we also have a very robust academic presence. We are consistently presenting at many of the major national and international meetings. This past year, we were awarded both a Best Paper Award and a Best Poster Award at two different society meetings. We only have, a small group, but we had over the last year over 20 publications amongst our team. And it's all about representation. I think this is important because we are not just representing for Moffitt, but we're representing for our patients and, for orthopedic oncology as a national community. So Dr. Benitier was served on the program committee for the Connective Tissue Oncology Society, which is an international society. He's also one of the section heads for the Bone Sarcoma group for the Children's Oncology group. And he's also the head of the Musculoskeletal Tumor Society membership committee. So he holds a lot of executive and senior leadership positions in some of the societies. And I've had the opportunity to work this year as the vice chair for our specialty day. Next year, I'll serve as the chair. And we also are serving and representing on multiple committees, including the Guidelines and Evidence-Based Committee and the Metastatic Disease Task Force. Next slide, please. And this is just a selection of some of the studies that we are involved in. And you can see it really spans the whole gamut. It includes things from socioeconomic factors, epidemiology, surgical outcomes, basic science, translational research. So we really have a great team that's got our hands in multiple different avenues to try to help push the limits for our patients. Next slide, please. And I'm just going to spend the last minute here just talking about some of the areas that we're doing research. Obviously, our passion is bone and soft tissue sarcoma. We spend a lot of time looking at the ways we reconstruct patients and the optimal outcomes for those patients, and including soft tissue sarcoma as well. We're trying to figure out how do we do a better job of determining if we've taken out every last cancer cell at the time of surgery, and how do we do a better job of making sure that our patients don't have wound complications, don't have functional complications as a result. And so you can see some of the selections of the studies that we have ongoing. Next slide, please. And one of the other areas that we really have kind of championed is metastatic bone disease. So we recently launched our metastatic bone disease clinic, and this is for patients that have metastatic cancer that's spread to bone. They are a unique patient population that are understudied, and we have multiple projects and studies going on looking at this patient cohort. Next slide. And finally, there's a lot of interesting studies, and these are collaborative efforts, multi-institution efforts, looking with not just some of the other disciplines within Moffitt, but also outside of our own institution to help try to push the boundaries on what we know about this very rare disease population. So again, just want to highlight some of the research that we have going on. Currently, we have over 30 active projects in our orthopedic oncology group, and we're just really excited about what we're doing. Next slide. And this is just more of the same. Thank you. Next slide. So thanks again, everybody. Really appreciate the opportunity to talk, and I'll hand it over to John to introduce Jonathan Metz.
Up next is Dr. Metz. So Dr. Metz, the pediatric oncologist, focuses on patients within our program in the adolescent young adult age group. These are patients aged 18 to 40. He is specifically focused on these patients, and he's going to talk to you now about that program within the sarcoma department. So go ahead, Jonathan.
Thank you. Can you hear me okay, John?
Yes.
Okay, great. Thanks so much for the time to present today. My name is Jonathan Metz. I'm a medical oncologist within the sarcoma department, and I'm a pediatrician by training. So I'm experienced in the care of patients as young as 0 and go up to age 40 at Moffitt. I'm going to spend a little time today talking about challenges in the cancer care of children, adolescents, and young adults, and what the Moffitt Sarcoma Department is doing to be a leader in this area. So sarcoma does not spare any age group. So patients below the age of 18, they'll experience about 1,200 cases of sarcoma each year, which comprises about 15% of all cancer diagnoses in kids. Contrast that with adults, where there will be 10 to 12,000, comprising about 1% of cancers. So the pediatric age group is heavily afflicted by sarcoma, and often these patients can benefit from the experience that Moffitt Sarcoma Department has, even though we do not directly take care of these patients at Moffitt. There's many challenges in the care of patients with sarcoma that are children, adolescents, and young adults. First off, the cancers are extremely rare. Secondly, their disease biology is quite different from that of adults. And this leads to a lack of novel therapies and also a delay in identifying new therapies. So even if we assume that every new drug that comes out for an adult is going to have an effect in a pediatric cancer, it's typically on the order of about 7 years before an adult drug will first be tested in children. So there's a huge lag time that leads to delays in advancements for the care of these patients. These patients also have unique psychosocial considerations. There is a transition in their level of independence from being a child through their adolescent years and into young adulthood, at different levels of family support, some with their parents as their primary caretakers, others transitioning through college years and young adulthood and moving into having spouses and other family members be responsible for being their support network. They may be in school or early in their career, and they may have to be putting these on pause as they enter treatment. Finally, a lot of these patients are entering the family planning period, and this, as you can imagine, creates a lot of difficulty when you're trying to plan a family around your cancer care. So when you add these factors together, this creates an extremely difficult and complex treatment environment, barriers to scientific progress, and there's the lasting effects of treatment on patients even that have survived their sarcoma. Next slide, please. So our sarcoma department is committed to improving the lives of these patients, and I place that into two buckets. Number one is clinical trials for children, adolescents, and young adults with cancer. And then number two is our Moffitt Adolescent and Young Adult Program. Next slide, please. Speaking first about clinical trials, I wanted to highlight a group called the Sunshine Project. This is a clinical trial consortium comprised of about 40 leading pediatric and young adult institutions across the United States that focus on children and young adult with cancer. It's sponsored by a Tampa-based philanthropic organization, the National Pediatric Cancer Foundation. Their website link is located below. And I'm proud to say that this program has been led by members of the Moffitt Sarcoma Department since 2005, starting off with Dr. Letson, moving then to Dr. Reed, and then with me serving in the leadership role for the last 3 years. This organization has been extremely effective and efficient in advancing care for pediatric and adolescent sarcoma patients. We've completed over 7 clinical trials, have 5 trials active, and 2 upcoming clinical trials. Most trials in the sarcoma space, but we also focus on pediatric brain tumors. The types of therapies that we have studied are numerous, from novel therapeutic agents to immunotherapy to cellular therapy, drug repurposing studies, as well as partnerships with pharmaceutical companies. And we have over 30 ongoing lab projects that this organization sponsors as well. And this directly benefits us here at Moffitt in that most of these trials enroll up to age 40, and some of them don't have upper age limits, so we are able to enroll Moffitt patients on these clinical trials when appropriate. Next slide, please. Also, in collaboration with Dr. Mullinax and the cell therapy team at Moffitt, we have brought tumor-infiltrating lymphocyte therapy to pediatric patients. So TIL therapy uses the body's own immune system to fight cancer, and is now an approved therapy for adult melanoma and is being studied in many other adults' cancer types, but we are the first to study this therapy in children. So there's a trial that just launched this past May with its first enrollment recently. That's a collaboration between Moffitt and our pediatric partner, Johns Hopkins All Children's Hospital. And it's built on lab studies that have been performed over the last 5 years that have been collaborations between myself and the Mullinax lab. And so we're excited to see this study take off over the next few years, hopefully establish the safety and early efficacy of this therapy in children so that we can continue to expand its use and learn more. Next slide, please. Moving on to the AYA Oncology program. AYA Oncology is defined as patients 15 to 39. Overall, it's rare for patients in this age group to have cancer, but when you look across the United States, it's not that rare. There's about 90,000 patients that will be diagnosed annually in this age group with cancer. Unfortunately, rates of these cancers are rising in breast cancer and colorectal cancer specifically. Fortunately, the death rate is dropping. You see, as the cancer rate has risen, the death rate has dropped, and so there's more patients surviving. These patients do have to often deal with side effects and long-term effects of their diagnosis and treatment long after the time that they are treated for their cancer. Next slide. And at Moffitt specifically, we've seen an enormous growth in our AYA population. Looking back as recently as 2015, we had 1,900 new AYA patients seen at Moffitt. That number has grown 72% in the past decade to over 3,300 patients in the 2024 year. That is on par or ahead of Moffitt as a whole and greatly exceeds the geographic population of Tampa, Florida, and the United States. Next slide. So this program is led by both the sarcoma department as well as the Department of Supportive Care at Moffitt. These are a few of the names that lead the program, including my partner, Dr. Haas, and our administrator, Deanne Voss. And we have multiple volunteers across the hospital in the departments of nursing, social work, and other physicians that help us to run this program. Next slide. These are the domains that the AYA program focuses on. We focus on educating AYA patients to take full advantage of all resources available to them. We focus on fertility. Many cancer therapies can affect patients' ability to have kids when they get older, and we want to make sure patients are able to access any resources to preserve fertility they can in a timely fashion. Navigation through the healthcare system, as well as psychosocial support and research. Next slide. For psychosocial supports, the AYA program produces web and paper-based literature that is handed out across Moffitt and is available publicly. We try to engage patients early with their social worker to make all resources available to them. We also host AYA-specific patient events once or twice a month. These are social gatherings where patients can just meet with their peers who are experiencing similar treatments to them. We have an AYA ambassador program where patients that have been treated at Moffitt can help the AYA program understand how we can do better for these patients. And we also host multiple AYA awareness events. Also inpatient in the hospital, there's an AYA lounge, a specific space for this age group where these patients can gain respite when they have some downtime in between their treatments. Next slide. For clinical service, fertility preservation is a very important goal of AYA. We want to make sure that patients are aware of fertility resources and the potential impact of their fertility care, as well as ability to preserve when indicated and desired. We partner with multiple local fertility preservation clinics to provide these services. And we're also launching an AYA consult service to more rapidly get these patients to fertility preservation, as well as address other holistic aspects of the AYA experience directly with AYA patients. Next slide. And finally, for research, the AYA program has been sponsoring research at Moffitt and beyond for the last 15 years. We published multiple papers in fields of disease biology, AYA patient treatment, quality of life, and health outcomes and behaviors. We hold an annual AYA research retreat and award yearly pilot grants and rolling seed funding. Next slide. So in conclusion, I hope I've convinced you that the Moffitt Sarcoma Department is a leader in advancing the oncology care, as well as the overall well-being of children, adolescents, and young adults with cancer. Thanks, and I'll hand it back over to John now.
Thanks, Dr. Metz. That was fantastic. I think that's a great example of one of the unique aspects of our sarcoma department here at Moffitt, and that we have this comprehensive and multidisciplinary group that focuses on these patients in the AYA. So thanks for leading that. All right, up next is Dr. Voss. She's a surgical oncologist in our group in the sarcoma department. And she's going to talk a bit about the facets of our practice now. Dr. Voss, take it away.
Thanks, John, and welcome everyone. Thanks for the opportunity to present. We're so thrilled to be giving this webinar. So I'm going to focus on the surgical oncologists in our sarcoma program. So I know there's some patients on the line, but just for clarification, Dr. Lazarides is an orthopedic surgeon. He talked about the amazing things that our orthopedic surgeons are doing. And then the other component of the surgical practice of our sarcoma department is made up of surgical oncologists. And we are general surgeons by training who've completed a general surgery residency and then done a fellowship in surgical oncology. And we do soft tissue sarcomas. We don't really do the bony sarcomas. And we focus a lot of times in the abdomen, but we also operate all over the body in the soft tissue, sometimes chest wall tumors, breast sarcomas. It's really a wide variety to what we all treat. And this is our group here. Dr. Ricardo Gonzalez is the chair of the whole sarcoma department at Moffitt, and he's also the chief of surgery at Moffitt. And he's been here the longest. I think he's approaching 20 years here at Moffitt. And then Dr. Mullinax, who you all have met, he's the section chief for our surgical oncology group. There's myself. I've been here about 4 years now at Moffitt. And then I also want to introduce Dr. Leah Hendrick. She's one of our current fellows who will be joining our group in just a couple months. So we've hired her and we're really excited. So we'll have 4 of us doing soft tissue sarcoma full time, which is a really large group to just be doing sarcoma. Next slide. So in general, here's just some brief stats. Are just the surgical oncologists. We see over 400 patients a year the last 2 years. These are our statistics. And, I think it's important to highlight that, we see not only sarcomas, but if you as a patient get a scan and have a mass and no one knows what it is, a lot of times you'll end up in our sarcoma department and be seen by me or one of the surgical oncologists, and we'll actually help you get the diagnosis. And I think that's really important because sometimes we know there's a mass and we have to figure out what it is before we can start treating it. And so we see a lot of those undiagnosed masses in our clinic. Some end up being sarcoma, some don't. Some end up needing surgery, some don't. But it's a great, if your primary care doctor doesn't know what to do, we're here to help with that. Next slide. Just talking for a minute about retroperitoneal sarcomas. This is a large part of our practice. These are large tumors that can develop deep in the abdomen. And for this, the statistics on this slide are showing just people who've been newly diagnosed with this. And I want to highlight that, what the definition of a high volume center in the world is if you see 10 to 12 of these in a year. And we see just initial tumors, almost 3 times that. So we're a very high volume center. And this, of course, these numbers here do not include recurrences because unfortunately, in this disease, often patients have recurrences that need additional surgery. So those patients are not included in these numbers. So we're really, by definition, extremely high volume. Next slide. There is an international group called TARPSWOG. This is a group of surgeons, medical oncologists, radiation oncologists, pathologists, who are dedicated to the treatment of retroperitoneal sarcomas. It has kind of a funny abbreviation. It's called TARPSWOG, which stands for Transatlantic Australasian Retroperitoneal Sarcoma Working Group. This group meets twice a year, and we come from all over the world and meet, and we fill one room basically because the sarcoma is so rare that we all fit in one room in a convention center to talk about this. But it's really exciting. People are talking about how they're pushing the envelope. And there is an international database where data is collected for patients who have their initial diagnosis of retroperitoneal sarcoma. And we at Moffitt do participate in that. We are collecting data towards that database, which is called RESAR. Next slide. So a little bit of a busy slide, but this slide is talking about a clinical trial that's open internationally. It's called STRAS-2, and I want to highlight it because it is one of the more important trials and relevant trials that's going on right now in retroperitoneal sarcomas. Moffitt is an enrolling site. In this, the US was a little bit late to the game. I think there's probably about half a dozen patients in the US that have been enrolled. And we do have a patient that's enrolled at Moffitt. And this trial looks specifically at patients who have their first initial presentation of either retroperitoneal leiomyosarcoma or dedifferentiated liposarcoma. And you can see sort of in the central part of the slide, there's 2 arms to this study. So that means the patients are randomized if they agree to participate in the trial. Half of the patients will have surgery for this disease. And then the other half of the patients are going to get chemotherapy first, followed by surgery. And the goal of this trial is to really understand, does chemotherapy for these 2 specific sarcomas in the retroperitoneum, leiomyosarcoma or dedifferentiated liposarcoma, does the chemotherapy improve recurrence rates, improve survival? Should it be standardly added to what patients are receiving? Because right now we don't know. It's It's really variable by institution who is getting chemo and who's just getting surgery because we don't have clear answers for this. And so this is an ambitious trial. It's international in many different countries. The enrollment has reached about 50%, so we're about halfway to the goal of the number of patients that want to be randomized, which is 250. And so this is plugging along. So we hope that a few years from now we have results. And Moffitt's, we're really excited to be participating in this trial. Next slide. Next, I want to talk about some of the clinical developments we've had over the last few years. I think a year and a half now, we've been doing these retroperitoneal sarcoma pathways. And, Moffitt as a whole was making a big push to sort of create pathways for enhanced recovery after surgery. And we came up with this in our department as a way to sort of classify how we expect our patients are going to recover. These are often big tumors in the abdomen. They can be the size of a basketball, the tumors that we're taking out of people's abdomens. Sometimes they're losing kidneys, part of their colon, intestine, liver, uterus. It's part of their stomach, spleen, pancreas, and one of the challenges of this disease is how heterogeneous it is, that the tumors can be many different places in the body. But we came up with these pathways to try to sort of classify, the severity of the surgery that the patient is receiving. And then that can help us, helps our fellows and our trainees sort of understand what's the expected recovery time, how long is this patient going to be in the hospital based on what kind of surgery they had. So just in general, we have 3 pathways, a green, a yellow, and a red. And green means we expect that you're going to stay 3 or 4 days. This is, for us, this is a smaller surgery, like just a kidney taken out or just an adrenal gland taken out through open surgery, no bowel involvement. The yellow pathway is a 5 to 6 day anticipated stay in the hospital. Maybe there's a bowel resection of some kind, a moderate length of case, like 4 hours or more. And then the red cases, we anticipate these patients are going to stay a week or more in our hospital. They've had multiple organs removed during surgery. Maybe the surgery itself was quite long, or there was some kind of vascular reconstruction. So we came up with these, and we're collecting data currently about how these patients are performing. Next slide. There are some commonalities to all the pathways, like, ideally all our patients are having a preoperative Zoom meeting with our enhanced recovery after surgery team to learn more about what to expect during and after surgery and what they can do to improve their recovery from surgery. And then there's some other sort of medical things that go into this in terms of the pain control and how we want people to be up and walking early after surgery. Next slide. These are some more specifics about the pathway. I think in the interest of time, I'm going to sort of skip over these, but we do have sort of expectations day by day, how the patients are going to recover based on the pathway. And we, of course, allow veering from these pathways as needed if problems arise, but at least gives us goals that we have for the patients each day of their stay. Next slide. I think we can skip a couple slides. This is yellow. The pathways are similar. It's just for yellow and red. The days where we're meeting different milestones towards discharge are just a few days later. Next slide. Okay. And then for a couple minutes, I want to talk about adrenal surgery update. So also within our department, besides seeing sarcomas, we also see adrenal tumors. That's just how we're structured at Moffitt. So I'm going to talk a little bit about that. Next slide. Our adrenalectomy case volume for the last few years is listed here, 50 to 60 or so cases per year. And I want to highlight that the definition of a high volume surgeon is 6 adrenalectomies per year. And I will say we often do that in 1 month here with our surgical team. We see all manner of adrenal tumors, benign to malignant, that make different kinds of hormones. We're a very high volume center. Next slide. One thing that's exciting, we're in the process of certification as a center of excellence with the Primary Hyperaldosteronism Foundation. We're working on this along with our endocrinology colleagues. These are aldosteronism. This is a disease of the adrenal glands where the adrenal glands are producing too much of this hormone. It's one of many hormones that the adrenal glands can make. And we see a lot of, these are very rare tumors. We see a lot of them here. And so we are in the process of being certified as a center of excellence. Next slide. Another thing we offer here that's more rare, I do these procedures. These are posterior retroperitoneoscopic adrenalectomies. These are laparoscopic adrenalectomies performed through the back. You know, in most centers in the country, these are done through the abdomen, laparoscopically or open. We do offer them here. I also do them through the abdomen, but I offer them through the back. And this cartoon sort of depicts how the surgery is done and how the patient lays during surgery. Next slide. This is what the actual OR table looks like. There's a pad that the patient rests on. Next slide. Here's what the trocars look like. It's a narrow working space. It's sort of either in the patient's right or left back, under the ribs, in between the hip bones in the back. Next slide. This is an example of the view. This is during a right adrenalectomy. It won't go into too much detail, but it's a really narrow working space, you know, like the size of an orange you could think working in. So it's quite narrow. It can be difficult. On the right side, you're working right by the vena cava, or the IVC, which is the biggest vein in the body. And you can see here the adrenal vein goes straight into the IVC on the right side. So that has to be clipped and divided in order to separate the adrenal mass. Next slide. Routine postoperative care. So for this procedure, you know, just like for laparoscopic through the abdomen, all patients are admitted overnight. Pain is generally pretty minimal. Patients are usually drinking clear liquids on the day of surgery, and then regular food the day after surgery, post-op day 1. And then the majority of patients go home on the first day after surgery, post-op day 1. So this is nice because it offers some other options for our patients who maybe aren't good candidates to have laparoscopic surgery through their abdomen because they've had a lot of surgeries before and there's a lot of scar tissue and they wouldn't be really eligible to receive laparoscopic surgery through their abdomen. Next slide. So, you know, we're one of only a few hospitals in Tampa that offers this procedure, and I'm happy to offer it to the right patients. And, you know, I have a very detailed discussion with the patient about, you know, which techniques we can offer and which might be best suited for them. And, you know, we offer robotic, laparoscopic, open, posterior approaches for our adrenalectomy patients, and I'm proud and happy that we can do that. Next slide. All right. That's all I got. Thanks so much for the opportunity to present.
Thank you, Dr. Voss. That was outstanding. Thanks for talking about the scope of things we do here at Moffitt. So as we close, just wanted to present a few slides here regarding the work of the foundation. So in sarcoma, I see there's actually a question in the chat regarding funding for cancer research. All of the things that you've heard today from the clinical trials to the work Dr. Lazarides discussed, obviously, you know, requires funding of personnel, funding of laboratory materials, et cetera. And so our Amanda Lee Foundation is within the larger Moffitt Foundation, and it was established in memory of a sarcoma patient. This allows for directed giving related to sarcoma research. Throughout the year, we have 2 primary events that support the Amanda Lee Fund, in addition to patient donations. In the fall, every year, we have a golf tournament called the Donco Jones Golf Tournament. In the spring, we have the Shootout. Next slide. So the sarcoma shootout is the spring every year. The date this year is March 21st. We invite patients and their families to participate, obviously friends and supporters as well. We raise about $60,000 every year that goes directly toward the Amanda Lee Fund. And the contact information is here for those that may be interested. Next slide. The Dawn Co Jones golf tournament. This was named after, again, one of our patients. Dawn Co Jones was an LPGA golfer. She was a patient here at Moffitt, and her husband and son founded this tournament several years ago to support the Amanda Lee Foundation. It's well supported by a wide variety of collegiate golfers and LPGA golfers, and also our patients and supporters. And so they've raised a significant amount of money, and this year we're going to do it again November 21st, Tampa Palms here in Tampa. And now I'm going to turn it over to Mark Ketterer. Mark is our foundation partner with the Moffitt Foundation, who helps to support the sarcoma department. So Mark, take it away.
Thank you, Dr. Mullinax, and I want to thank all of our panelists for being here today, and thank you for joining us. As Dr. Mullinax had said, I'm the foundation liaison to the sarcoma department. And the one thing that we realized here tonight is that, there's a lot of research going on. And I know Dr. Lazarides even mentioned special research topics that he wants to explore even more. And a lot of this gets done through the work of philanthropic giving and seeing some of our patients and friends in the community give to Moffitt and be able to further some of the research that we have going on. So please, if you have any interest in supporting the research happening at Moffitt, please reach out to me. Or if there's any special interests and you'd like to come in for a tour and see it firsthand for yourself, we'd be glad to have you. So without further ado, this is one of my favorite parts of the evening. We're going to have our question and answer, and I'm going to hand it back to all of our panelists, and we'll go from there. Thank you again.
All right. Thank you, Mark. So there's a few questions in the chat. We've been answering some of the more straightforward ones as we go along, but I think now we'll take a little bit of a deeper dive. So the first question, I'll put it for Dr. Metz. So there's actually been two there in the chat regarding ctDNA. Can you talk a little bit explain to the group what ctDNA is and how that's being used here at Moffitt for patients with sarcoma?
Sure. Thanks, John. So ctDNA stands for circulating tumor DNA. This is genetic material that's produced by the tumor and then probably sloughed off with dying cancer cells or through cell turnover and ends up being just floating through the bloodstream to eventually be metabolized. And so the idea is to draw a blood sample and measure that tumor DNA in the bloodstream. And the ways that it could potentially be used are numerous. It could be used as a way of monitoring a patient's disease for recurrence after they finish their treatment. Having a high level at the time of diagnosis or after surgery could inform which patients need to receive chemotherapy. And it could also potentially be a way to, hopefully at some point in the future, maybe decrease the number of scans we need on patients if we have a very sensitive blood test. It's actually standard of care for some cancer types, including colorectal cancer. Sarcoma is a bit behind that timeline, mainly because of the rarity of our disease. Even though we're a very large sarcoma center, when you split our diagnoses up amongst 80 different types, it's very hard to get the numbers, but we're getting there. So multi-institutional studies have now shown us that high-risk sarcomas, we're getting better and better at predicting who might have the highest chance of recurrence after surgery and radiation based off the ctDNA level. So we've had early discussions with commercial ctDNA suppliers about testing this in our high-risk patients. And so we hope to be in that space very soon. And then also the Sunshine Project that I talked about earlier is actually running the largest ctDNA study in pediatric sarcoma right now. We're probably about 70% done, but due to the rarity of that disease, it requires huge national collaborations to get enough patients to create informative data. So we're also participating in research in that space.
Thanks so much. Great answer. I'm gonna ask Dr. Voss to address this. So there's a question in the chat about gynecological sarcomas or low-grade endometrial sarcoma, and how is that different from general soft tissue sarcoma?
Okay. Well, I don't know that we mentioned there's 100 or more different subtypes of sarcoma, and they all act quite differently. For sarcomas of the uterus, usually hysterectomy is done. Sometimes, unfortunately, these are caught after, a leiomyoma or a fibroid, which is thought to be a benign tumor, is removed. And so then a hysterectomy has to be done. These are different, they're different kinds. They're all kind of in the sarcoma bucket, but they're distinct kinds of cancer. Every type of sarcoma acts a different way. It has a different predilection for how often it likes to recur in the area where it originally came from, or for how often it likes to travel to different organs of the body. Sarcomas like to go to the lungs, generally speaking, but not all of them do. Some of them have different patterns of spread to bone or other tissues. And so for the endometrial, I would say just in general, each sarcoma, when I'm seeing each different kind of sarcoma, I'm looking at what type of sarcoma it is. That's almost more important to me than necessarily where it is in the body. It's going to act a particular way, but I also take into account, of course, which organs it's touching and what kind of surgery we're talking about. The histology, the specific type of sarcoma is really what's important when we're designing the treatment plan, and then of course how far it's spread, what stage it is.
That's great. Thank you. There are a few questions in the chat that are patient specific, and as I said at the beginning, we obviously can't give medical advice or comment on specific patient cases. However, there are a couple of questions about immuno-oncology and the use of the immune system and immunotherapy to treat sarcoma. I'll just briefly state that at Moffitt, there are sort of two arms to that. One is standard of care, and these are medications such as pembrolizumab that have been FDA approved for other indications, and our medical oncologists certainly recommend these when appropriate for patients with sarcoma. And then the other side, I would say, are clinical trials. And so we have a robust clinical trial portfolio, including cell therapy, which is a form of immunotherapy, and also the recently FDA-approved cell therapy, which is specifically approved for synovial sarcoma. So immunotherapy is certainly a pillar. If you think of pillars of cancer treatment being surgery, chemotherapy, radiation, and now our fourth being immunotherapy. And again, in consultation with our medical oncologist based on your specific case, that's certainly something that is considered for every patient. Dr. Lazarides, there's a question here about tumor board. What do we talk about at tumor board? Why don't you highlight for the group what is tumor board and how does that work? Why is it important?
Yeah, I think tumor board is probably one of the most important subtle things that's involved in sarcoma care. And really, what it is an opportunity to create a patient-specific plan with a group of experts. And so there's not a lot of places quite like Moffitt when it comes to sarcoma. We've got about 25 physicians from the radiologist, the radiation oncologist, the medical oncologist, the surgeons that are all participating in this tumor board with specific expertise in sarcoma. And what it is an opportunity to discuss those challenging cases and find a solution that's specific for the patients.
That's great. Yeah. Okay. Let's see here. I'm going through Dr. Voss. How is retroperitoneal liposarcoma staged?
Yeah, it's a great question. So sarcoma staging is a little bit different. So any tumor that's low grade or looks sort of much less aggressive under the microscope is stage 1, no matter what size it is or what location it is. That's very different than other cancers. And then all the tumors that are considered a moderate or high grade are in a stage 2 or 3 category, with tumors less than 5 centimeters being stage 2. And if they're greater than 5 centimeters, they're stage 3. And then if it's spread to other areas of the body, including lymph nodes, which is not common in sarcoma, but lymph nodes or lung or other far areas from where the tumor is, that's stage 4.
Great. There's one here about recurrence rate. So I guess I'll take this one quickly. So, recurrence rate, as we talked about, there's sort of two types of recurrence, one being local.
I think we lost John.
General recurrence rate for these subtypes. But again, in working with your surgeon and medical oncologist, they'll be able to help you with that for your specific case.
John, do you mind just repeating that? We lost you for a minute.
Sorry. So recurrence rate refers to both local, which is where the tumor started, and distant, which means metastatic spread, or where the tumor may go away from where it started. And so for each subtype, there's a different general recurrence rate, but more specifically, each patient has a recurrence rate that's predicated on their tumor factors. And so that specific risk is something to discuss with your physician at the time of consultation. Um, Let's see. Go through here. Let's see. And maybe for Dr. Lazarides, a question about osseointegration, specifically about the prep necessary for bone grafting. Have you found any negative effects of those products that might be vulnerable to fostering potentially recurrence of the disease itself?
Yeah, so I think osseointegration is a specific option for amputees, and so obviously it's a very specific patient population. And when we think about osseointegration, it's not necessarily the same technology that's used for all of our reconstructions. But the short answer is no. We have not seen, for instance, angiosarcoma specifically or other sarcomas, as long as we have done the appropriate surgical treatment for that specific indication, the implants and the way we're putting them in, there has not been a specific increase in the risk of those specific cancers regenerating or regrowing, is the short answer.
Right. Let's see. All right.
There's a question about further treatments for sarcoma patients to enhance their health. I would say we don't have anything. We do have when people are about to undergo surgery, we have the enhanced recovery program that patients go through, and that's helping them prepare for surgery. But beyond that, we know in general for cancers that patients who exercise and who have a healthy weight have better recurrence and better survivals just from cancers across the board. So when patients ask me, like, do I need to take this supplement I heard about, or do I need to spend all this money on some things, my neighbor told me about, I tell them, no, like exercise and maintain a healthy weight and eat well. Like those are the best things you can do for your body when you're fighting cancer, sarcoma or not.
Yeah, and to piggyback on that too, I always tell every patient your immune system, we talk about immunotherapy, but your immune system is probably one of the most important things. And along all the things that Rachel is discussing are things that are going to make your body healthier to be able to ward off cancer. So I would echo everything that Rachel just mentioned. And John, there's one other question just about radiation
Yeah,
and dose limits.
I was going to get to that.
Um,
I think it's important, as I said at the beginning, we can't comment on specific cases, but radiation is certainly one of the mainstays of treatment for patients with soft tissue sarcoma. And specific limits in terms of dose or treatment to the patient is really something to discuss individually with the radiation oncologist. There are limits, but that's different for each patient, each anatomic location. So, we can't get really too specific with the answer to that question here this evening.
I think it all highlights making sure that you're at a center that understands the comprehensive nature of your care, all the things that you've been through, and also what your body can take, because everything has a side effect. And one of the benefits of being at a place like Moffitt is simply the fact that you have an entire team all under one roof that know your care from start to finish and all the intricacies therein.
Yeah, no, it's a great point. And I think that follows with the most recent question asked about lymphedema. So lymphedema is something that we see in the extremities, in patients that have had an operation or an operation with radiation. Obviously, that can be a long-term and sometimes debilitating side effect of the treatment itself. Here at Moffitt, we're really fortunate to practice with some outstanding physical therapists and also some plastic surgeons who specialize in surgical management of lymphedema. And so for those patients that have lymphedema, seeing one of us or one of our partners can certainly help to direct that therapy most appropriate. But yes, there are several techniques that can address this in escalating fashion in terms of of intensity.
I know our plastic surgeons, they're starting a lymphedema clinic, Dr. Curray, and some of the other plastic surgeons have an interest in this for treating it even after it's developed.
Yeah.
And then just, our center just for the immune therapy for synovial sarcoma and some of the questions there. Our center was one of the ones that was kind of the leaders in that trial. That trial is typically for metastatic, failed standard lines of treatment, synovial sarcoma. For a lot of these rare treatment or rare cancers and these rare treatments, it can be challenging to try to go off label and use these treatments. But the reality is that sarcoma as a whole is an aggressive cancer, synovial sarcoma in particular. And there is a risk of recurrence, which is why it's really important to make sure you're getting a comprehensive treatment plan, going through a well thought out treatment for you specifically in your cancer, but also having people that are going to keep a close eye on you for years to come. And we follow our patients for years after surgery with routine imaging and surveillance.
Yeah, I think that's a good way to end it. I think what you've seen this evening is that, the sarcoma department at Moffitt is a group, a multi-specialty group that encompasses the entire gamut of cancer treatment for patients with these rare types of tumors. We're certainly honored to care for our patients, and we're honored that the patients choose us here at Moffitt. And we appreciate your support this evening. So I guess I'll thank my panelists, and we'll thank Mark and Stacy and Tiffany for organizing this. And thank you very much.